There is a type of patient that routinely frustrates healthcare professionals. I know because since 1983, I have interviewed over 7,000 of them. He or she might have just a single symptom.
I've had low back pain for about 4 months.
They might have no obvious signs of anxiety or stress.
Sometimes my back goes into spasm right on my right side and it'll just seize up, but it's only when I try to bend over, so it feels like I definitely can't bend over.
Or they might have multiple symptoms, accompanied by indications of psychological distress.
I also have chest pain. I don't know if that's related, but I've been wearing a heart monitor, so I don't know if it's, they're still ruling out to see if it's from my heart. And I know that's not your specialty, and maybe it's not related at all, but so I'm just really stressed that I don't know if there's something wrong with my heart, but I had to go to the ER and they thought that I was having a heart attack and they said it's just a panic attack. And I'm like, how can it be a panic attack? Because it felt like I could feel that my chest pain was intense. And at the same time, my legs are collapsing and I was wetting myself and everyone was like, oh, you'll be fine. We saw you.
What these patients share is that diagnostic tests fail to reveal an organ disease or structural abnormality that can account for the symptoms. They are what this course is all about. This course is based on concepts that have been presented to a wide range of healthcare professionals across North America and Europe and in several graduate school courses. The fact is, if you know what to look for, you can diagnose and treat these patients as successfully as any of your other patients.
But first, we want to briefly review the large number of terms used to describe patients whose symptoms are not explained by diagnostic tests. These include psychosomatic, medically unexplained symptoms, and somatic symptom disorder, among others.
Other terms used informally even express a degree of contempt for patients, as if they were to blame for their condition, such as all in their head, crock, malingerer, hysteric, or supratentorial overlay.
Fortunately, there is a term that clinicians experienced in this field agree captures what is truly going on. It is the one we have chosen to name this course: Psychophysiologic Disorders.
This term emphasizes that although the process originates in the brain, it is physiology that manifests symptoms in the body. Unfortunately, the care of these patients, even by otherwise excellent professionals, can be appalling.
This woman had abdominal pains for about 9 months. She was evaluated with every conceivable diagnostic test, including cutting an internal muscle that regulates the flow of bile. No explanation for her condition was identified, so she was referred to Dr. Clark for a second opinion.
I reviewed your records, and I noticed that during the 9 months of your illness, no one asked you about stress in your life. Have you had any significant issues recently?
Well, I don't know if it's relevant, but I live with a partner who's been physically violent toward me.
How often does that happen?
2 to 3 times a week.
How long has that been going on?
9 months.
Which is exactly the duration of your pain. I don't think that's a coincidence. With the help of a social worker, this patient was able to end the relationship with her violent partner, move into her own apartment, and her abdominal pain was completely relieved within a few weeks.
Dr. Clark informed the previous doctor who had referred the patient about the successful outcome and received a surprising and disappointing reply.
What the doctor had missed was the correct diagnosis. Despite being an excellent physician otherwise, clearly he had excluded from his job description the need to investigate illness linked to psychosocial stress.
This patient experienced 9 months of time-consuming, uncomfortable, expensive, occasionally risky, and largely unnecessary diagnostic tests, while continuing to suffer not only the stress-related abdominal pain, But the domestic violence that caused it.
Fortunately, we can do a much better job for these patients.
Welcome to our course on Psychophysiologic Disorders, or PPD for short.
This course will teach you how you can diagnose and treat PPD as successfully as organ diseases and structural abnormalities, whether you're a medical clinician, a mental health professional, or a behavioral health consultant.
You will learn techniques that can achieve outcomes for PPD patients that are far better than is usually the case. You will also find that your frustration level with these patients will decrease substantially.
It was tremendously rewarding when, after a long learning curve, I was able to understand how to successfully manage these seemingly intractable cases. Let me share one example.
A 50-year-old woman had attacks of nausea, vomiting, and dizziness 6 to 10 times annually for 15 years. She felt well between attacks. She was hospitalized 60 times at a well-known university, but with no diagnosis and no effective treatment.
By knowing what to look for, I found the stress that caused her illness and successfully treated her in a little less than an hour. She never had another attack.
Despite the power of this stress, neither she nor any of her doctors had uncovered the connection. Once she saw that association, the stress lost its power to create symptoms.
Only a fraction of patients recover so quickly, but even those who need more time and treatment express great relief that they are at last on a pathway toward healing.
We will cover exactly how this patient was diagnosed later in the course, but next, in Module 2, we will get into more detail about the nature of this form of illness.